All right, let's talk about something really specific but super powerful in lung ultrasound, the fluid bronchogram. This one little sign, it can be the key to solving a huge diagnostic puzzle right there at the bedside.
So, imagine this. You've got your probe on a patient's chest, and you see it, a dense, consolidated lung. Right away, your brain is racing. Is this pneumonia? Should I be thinking antibiotics? Or is this a lung collapse, atelectasis from some kind of blockage? Because that's a totally different ballgame, right?
Well, the clue that can crack that case for you is often this thing called the fluid bronchogram. It's the visual evidence you need that can really push you in one direction over the other. It's a game changer.
Okay, so what are we even talking about here? A fluid bronchogram is basically when you can see the little airways, the bronchi, filled with fluid inside a part of the lung that's all gunked up and consolidated. See, normally you can't see these at all in ultrasound, but when they fill up with fluid, bam, they just pop into view.
And here's a great way to think about it. Forget all the jargon. Just picture dark, fluid-filled rivers carving their way through solid ground. That's exactly what a fluid bronchogram looks like on your screen. It's a really powerful mental image to hold on to.
But wait a second, how do we even see these rivers in the first place? I mean, a normal healthy lung is filled with air, and that air acts like a total shield against ultrasound waves. So let's get into the physics of how the invisible suddenly becomes visible.
Okay, this is the key to understanding everything. On one side, you've got a healthy lung. It's full of air, and it's basically a brick wall to ultrasound. The waves just bounce right off. But when that lung gets consolidated, like you see on the other side, all that air is gone. It becomes dense, almost like liver tissue. And just like that, it goes from being a shield to being a perfect conductor for sound.
This process, this consolidation, is what creates what we call an acoustic window. It's like it literally opens up a window, letting our ultrasound beam shoot right through so we can see what's going on deep inside all these structures that were totally hidden just moments before.
All right, so the window is open, we can see inside the lung. Now what? Well, our number one job is to figure out what we're looking at. Specifically, we need to tell the difference between airways that are filled with fluid and airways that are still filled with air.
In the fluid bronchogram, it has two dead giveaways. First, it looks dark on the screen. The technical term is anechoic, because fluid doesn't really bounce echoes back. And second, and this is a huge clue, it's usually static. It just sits there. It doesn't move when the patient breathes, at all.
Now look at this side by side. The difference is just night and day. Fluid bronchograms, dark and static. But their cousin, the air bronchogram, is the total opposite. It's bright, we call that hyperechoic, because the air is super reflective, and you'll often see it moving as the patient breathes. We call that dynamic.
This chart just breaks it all down beautifully. Zero in on that suggest row. See? A bright, moving air bronchogram tells you the airway is probably open. But a dark, static fluid bronchogram, that screams blocked airway. And that one little observation, man, it can totally flip your whole diagnosis on its head.
So let's dig into that. When you see that signal, that sign of a blocked airway, what's actually going on inside the patient? What's the pathology here? Here's the absolute bottom line. The second you see a fluid bronchogram, your brain needs to light up with one word: obstruction. It means air is hitting a roadblock and can't get through. So what happens? The airway behind that block just fills up with junk. Mucus, pus, you name it. And what's causing that roadblock? Well, the classic textbook cause is obstructive atelectasis. A lung collapse because of a big old mucus plug, or maybe a tumor, or even something they aspirated. Yeah, really bad pneumonia can sometimes do it. But the fluid bronchogram is like the poster child for atelectasis.
So this gives you a really simple but powerful mental checklist at the bedside. Step 1, find the consolidation. Step 2, look for bronchograms inside it. Step 3, ask yourself that million-dollar question. Are they dark and are they static? And if the answer is yes, boom, you should be highly suspicious of an airway obstruction and probably atelectasis.
Okay, great. It's a neat diagnostic trick. But let's talk about the so what. Why does getting this right really, truly matter for the actual human being lying in that bed?
It matters because it changes what you do next. Spotting a fluid bronchogram could be the thing that makes you pick up the phone and call for a bronchoscopy to go clear out a plug. It helps you figure out if blasting them with antibiotics is even the right move. It gives you a real sense of how sick they are and just how much gunk you're dealing with.
Honestly, if you forget everything else, remember this slide. This is your cheat sheet. You see a fluid bronchogram, your brain goes blocked airway.
Probably atelectasis. You see a dynamic air bronchogram, your brain goes, open airway, probably pneumonia. It's that simple, and it's a massive fork in the road for your diagnosis.
And this right here, this quote, it just nails the core idea. The whole thing boils down to one simple question. Is air getting through those airways or not? Is it open or is it blocked? And ultrasound is what gives you the answer right there in real time.
So I'll just leave you with this thought. The very next time you're scanning and you see lung consolidation, you now know exactly what you're hunting for inside of it. You're not just looking at some gray blob anymore. You're actively looking for evidence, open airway or blocked airway. Because finding that clue, that can literally change everything for your patient.